Hello, I'm Professor Béatrice Cochener.
And I'm Dr. Pooja Khamar, and welcome to our first episode of the 3-part Independent Medical Education video interviews series of refractive surgery.
Today, we are talking about the strategic personalization to this way of understanding who is in your chair and how maybe we can influence our treatment decision. In other words, how we can customize all of these.
So first we'll look at the two common patient profiles, the one who aligns with our approach, the each patient everyday lifestyle, and the second one who is the emergent presbyope.
To start with that, we have a good reference. We have this survey that comes from the ESCRS 2024.
When you see a data like this, it gives you a lot more information about what's the reason you are lacking a particular technology or why you are not able to incorporate a particular technology in your clinic. It tells you how to improvise and where to improvise. Do you think is this knowledge gap with the survey is something you can see even with the experienced surgeons?
Yeah, it's what I'm saying. I think that, it's all about innovation, the way we are moving, integrating new tools. And we have many people around us who are not reconsidering or changing the habits. So it's all about how we can implement our strategy in integrating innovation. It's all about progress and again, how we can improve. What about the position of the patients? Because the doctors define their own ideal and would say reference. Do you think that the patients are becoming more complex than they used to be in terms of knowledges and expectations?
Yes, absolutely. Like if you see maybe 10 years back, a patient used to come to a doctor and whatever surgery a doctor would advise in X, Y or Z, the patient will completely go for it. But nowadays, they've done the research quite well before they come to the doctor. You've screened the patient and you feel that LASIK would be the best procedure for it. But the patient may want an phakic-IOL. It makes your job easy and difficult at the same time because the patients know a lot. If you're not keeping up with the pace of the technology, then probably it could be challenging.
Yeah, but the Google doctor, it's a risky situation because they pretend to know more. And so it's all about for us to be strong enough and to be good in communications to return the position in terms of power, to remain the doctor as decision maker. I must say that the nicest situation is when you get this kind of complicated patient at the end. They say, okay, but I don't care. I trust what you are saying. Absolutely. It's exactly what we need to move on a safe way to refractive surgery.
So now let's talk about this young digital initiative, and it's a burning question nowadays, counseling for this younger patients who spend most of their times on the screen.
What can we do in terms of a decision tree for the procedure that we will recommend? If there is any problem with the ocular surface, I would maybe try to manage on a good way this ocular surface, and if it's difficult to control, I would maybe forget about any lamellar surgery. Even for instance calyx, because even if it does protect on a better way, this potential dryness, I think that it's something that we should keep into consideration. And why not even thinking about phakic-IOL?
Absolutely, absolutely. I think you're absolutely right here. If you have had any patient with an ocular surface disease or an issue, first would be to treat the ocular surface and bring it back to a healthy state. First would be treat the ocular surface, go for a phakic-IOL. If phakic-IOL is not permitted due to any inclusion criteria or the selection parameters, then do a deep counseling, try to avoid a surgery, but if it's not possible, then probably do a calyx procedure at a deeper
no, I think that it's a good point. But first of all, we should also inform the patient. They need to be sensitive to the fact that the tear film got a refractive power. And any fluctuation, any changes, or even refractive surprise can be related to that. So we need to make the patients becoming their own actor in their own health management. So maybe now we can change the generation. Let's move to the aging eyes.
If you are even evaluating a patient who's in their 40s or 50s for a refractive surgery, the reason they've come to you is they want to get complete independence of glasses. You're not just dealing with the the myopia or hypermetropia here, but we are also dealing with presbyopia here. We have to set their expectations right.
In my experience, I always start to explain what is presbyopia. Most of the myopic people who are getting in this range of 40 to 50, they want just to get rid of their glasses without considering that it's going to become a nightmare, because we spend 2/3 of our life in intermediate and near vision.
We do some test, like a simulation test, after getting rid of the myopic refractive error, or even if, let's say, we are doing a presbyopic laser for them, they may need a glass for reading, or there is something like neuroadaptation where the brain has to get used to this new vision. If they are younger, the neuroadaptation doesn't take a longer time, but in older patients, it sometimes stretches 6 months. So we do two things. If we explain the patient what is presbyopia, as you said, and how do they want to go ahead and correct the glass power. You either explain that you completely get rid of distance glasses and whenever needed wear reading glasses. That's the correction of myopia for distance, but the presbyopia stays. We do a contact lens trial for them. We make them wear contact lenses
for just one day.
Just one day, and tell them that so they will come to know that there's going to be a problem.
Yeah, because most of these patients, especially myopic ones, you will target monovision.
Yes, and if you are doing a monovision, then give a different set of contact lens and then reading glasses on top of it. Just a simulation at this point of time helps them understand what they are getting into, and then along with our counseling, I think they can take a better decision about whether to do a surgery or not.
So to sum up this first episode, we are facing difficult patients, new surrounding conditions. We need to manage information, selection, evaluation. So that concludes our first episode from the IME educational program from the ESCRS.